Hello everybody, this is me, Dr. Sergio Rovinsky from Shoulder Planet, here from São Paulo, Brazil. I am very honored to be participating here from Wiroc, this lovely meeting organized by BOSS, Bombay Orthopaedic Society, and I invite you to see all of the videos that I have sent to this wonderful meeting and to learn the most you can with them. And if you have any doubt, don't hesitate in sending me an email. My email is sergio@shoulderplanet.com.br. I thank all of the organization of this lovely meeting, and I hope you have fun seeing all my videos, and Dhanyavad. Massive rotator cuff lesions are the most difficult kind of lesions to treat, and nowadays we know that there are quite different patterns of massive lesions in the shoulder. In this case, I am presenting a case of a 64-year-old woman that was having pain over her left shoulder for the last 3 years with very typical signs and symptoms of cuff pain. This is her MRI, and this is a coronal view in T2, in which we can see a quite retracted lesion of the supraspinatus with some poor quality tissue in the insertion area. In this image, we can see a sagittal view still in T2, revealing a large and anterior lesion of the supraspinatus with a quite hooked acromion. And finally, this is an axial view still in T2, in which we can see that a large anterior lesion was here and present. Arthroscopic management was indicated, and so this is her arthroscopy. So this is her arthroscopy. This is a left shoulder. We establish an anterior portal with a spinal needle. And once we established the anterior portal, we first evaluated the biceps, pulling it out of the pulley, and it had a lot of synovitis, so we decided to perform a tenotomy. Then we took a fast look in the subscap that was obviously okay, like it was in the MRI and in clinical findings in the office. And then before doing the tenotomy, we performed a very fast and simple debridement of the anterior rotator interval. So then we performed the biceps tenotomy in a very standard fashion using an arthroscopic scissor, and once the tenotomy was done, we performed a very fast debridement of the biceps anchor, and then we moved it to the subacromial space. So then we went to the subacromial space and removed all the bursa and the synovitis. Now we can see a very large lesion as we saw in the MRI. So we started just cleaning the greater tuberosity to have a better look in the of the lesion, and then we cleaned the lateral gutter and the anterolateral gutter. This is a very important part of the surgery, and now we are detaching and cleaning the internal deltoid fascia to have a better approach to the subacromial space. So then we established an anterosuperolateral portal with a spinal needle and moved the camera to the lateral portal. So now we are working through the anterosuperolateral portal, assessing with a grasper the tendon mobility. The tendon was in quite a good shape, but not very mobile. So we started to perform a lot of releases, working through the posterior portal, first with electrocautery to avoid some bleeding that is very typical in this area. And we released all the adhesions between the cuff and the distal clavicle, and then we reassessed the tendon mobility, and we can even grasp the tendon as we are seeing now to have a better debridement of all the adherences. Then we entered with a small osteotome and released all the adherences between the inferior part of the posterior superior cuff and the superior part of the glenoid, and working for the posterior portal, we still had to remove some adhesions in the subacromial space. After that, we reassessed mobility. The tendon was reasonably mobile. The tendon was, as I have said, in good shape, but not very mobile. So at that moment, we decided that we would have to medialize the footprint and to create a new bony bed, a little bit medialize it. And so we performed a very simple and fast debridement of the edges of the lesion. This is what we are doing now. And then we started to medialize the footprint. So we entered with a soft tissue shaver to clean the greater tuberosity for the anterosuperolateral portal. And then for the posterior portal, we entered with the burr, and very gently, very softly, we started to create a new bony bed. So medializing the footprint. This has to be very gently and very softly. And now we can see that a new bony bed was created. So at that moment, we entered with a soft tissue shaver for the posterior portal, just to clean the synovitis of the anterosuperal, of the anterolateral gutter, and then using a spinal needle, we established a good position for the first anchor. So then we put a 5.0 double-loaded anchor, a metallic one, and after the anchor was put, we just tested it, and it was very stable. And then using a bird beak entering through the posterior portal and a grasper working through the anterosuperolateral portal, we passed the bird beak through the tendon, and in a retrograde fashion, we passed the first suture through the tendon. At that moment, we isolated the first suture in the posterior portal, using it as a waiting portal, and repeated the procedure using a bird beak, and then we, in the same way, passed the second suture, the blue one, in a retrograde fashion. At that moment, we would have to tie both knots, but in order not to make a mess with the knots, we like to isolate them in different portals. So we isolated the first suture, the blue one, in the anterior portal, and then we isolated the two parts of the white suture in the anterosuperolateral portal. Then we fastly moved the camera to the posterior portal and tied the first knot for the anterosuperolateral portal, and we then moved the camera back to the lateral portal, remove it for the anterosuperolateral portal, the sutures, and then we tied the second knot. After the knot was done, we would have to reassess the tendon coverage, and still there was a reasonable part of the head to be covered, even with a medialized footprint. So we would have to do the same thing. We just reassessed the tendon mobility. It was reasonably mobile, so we put a second anchor as posterior as we could, but with a very safe distance from the first anchor. And then we put a double-loaded anchor too. Once the anchor was in place, we just tested it. It was very nice, and we would have to do the same thing. So entering for the posterior portal with a bird beak, we passed the sutures, the first one in a retrograde fashion, out of the posterior portal. This is what we are doing now. And at that moment, we decided to tie that knot, so we would have to isolate very carefully the white suture, because we don't want to make a mess with the suture at that moment of the surgery. So we put the blue one out of the anterosuperolateral portal, and this is what we are doing now. And then we would have to tie the first knot of the second anchor. Now we are tying the first knot of the second anchor, putting a lot of pressure in order for the tendon to heal in the new bony bed, in the medialized new bony bed. And after the knot was tied, we would have to do just the same thing. So entering for the posterior portal with suture passer, we passed a number 2 Prolene, and we put that with a grasper out of the anterosuperolateral portal, and in a retrograde fashion, we passed the white suture through the tendon and out of the posterior portal, and then we would have to do the same thing back again. So we would have to put the white suture out of the anterosuperolateral portal, and once it was in the anterosuperolateral portal, we would have to tie the fourth knot, the second knot of the second anchor. So now we are tying the second knot of the second anchor, and after the knot was cut, that was the final image. We can see that the tendon was very nicely reattached to the greater tuberosity with a good reattachment, but with no tension. This is very important. At that moment, we felt so very free and comfortable to perform an acromioplasty. So we detached the coracoacromial ligament, and then we entered with a bird to perform a very standard and simple acromioplasty, a formal acromioplasty, and that was so the final image, in which we can see that the tendon was really fully reattached with no tension and with a very nice footprint. And at that moment, so the surgery was then finished.